Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
All right, this is a momentous day because Ashley is back with the podcast. It's been probably well over a year since you were on. I think so. And this is the first episode where you are going to be on the YouTubes since I've started putting episodes on YouTube. So, we're going to be doing some unscripted listener questions here. So before we get into it, let me bring up a couple of things. I have the Patreon account. Thank you to everyone who has signed up. It is dirt cheap.
Somebody actually mentioned it to me, though, the other day. They were asking me about your podcast, and it's not somebody who follows you right now. And they were like, oh, he should do a Patreon account. And I was like, well, actually just did. He set one up.
Yeah, it's $3 a month. It is dirt cheap, and it really helps me out with paying for the podcasting platforms and all this stuff. Also, I'm never going to be charging anybody for the content. The podcast, the education, the reels, it's always going to be free. But Patreon subscribers do get priority DM access because the DMs on Instagram are just complete. You have access to them. You see it. It's out of control. There's
like hundreds a day.
I don't know about hundreds a day, but
I mean, like not hundreds of people, but if you add up all the messages from each person that comes through on a daily basis, it's a lot.
It's a lot. So if you get a heart or a laugh tap back, don't be offended. Also, if you don't get a reply, just reach back out and say, hey, I didn't get a reply. But if you really want access to the DMs, Patreon has a DM feature, and I keep the notifications on, and it's kind of my way of saying thank you to the people who are donating $3 a month to help out the podcast. Now, I have always been hesitant to entertain sponsors. You may possibly, this is not definite, see some sponsorship coming down the pike. I have a meeting this week with a big company who wants to sponsor the podcast or who has expressed interest in it. I am not going to be a sellout. My hard rule is that I'm always going to say what I want to say. And if it's a good product that I believe in and a good ethical company, I will certainly happily take some money from them, from their coffers, to rep their product. But I will never be a sellout. Like I have said before, that if Philips came to me and said, hey, we'll buy you an oceanfront house to rep the Tempest Pro, will never happen. I would tell them, no, thank you.
Stick your Tempest here.
Yeah, and probably leave the thank you part out. But if it's a great product and they say, hey, we've heard you talk about it before, we'd like to sponsor you. And if you just say, hey, this podcast is sponsored by X, I am entertaining doing that. I have a meeting to do that.
Not
this
X
week.
Like Twitter. He didn't mean that.
Not
sponsored by X.
Yeah, I'm not being sponsored by X. But I will not be a sellout. I have had a company before reach out to me, and they wanted to throw some money my way to rep their product, and I think they have a shit product. So I didn't entertain it. Not interested in your money, because I'm not one of these content creators who's trying to pay for my life off of this podcast and this platform. This is just something extra I do because I like doing it. So stay tuned. That one piece, I will keep going. That one piece or that one business that wanted to sponsor me, I think they generated a lot of crap AI content. I have been really shitting on people who use AI to create their content. That really bothers me.
Like what do they put in a topic and then AI just does whatever?
Yeah, there's a couple people. There's one in particular. I won't say his name because it wouldn't be humble of me to do that. But it'll be like, hey, check out my newest blog post on capnography. And you open up the blog post and every blog post follows the exact same structure. Capnography is a diagnostic tool that can be used in, here are 34 points about capnography.
So it's like when you search something in Google and the AI bot like gives you a
That's
synopsis of
exactly what it is. But I think it's a higher end
Yeah,
AI
yeah.
that he is using. But that really bothers me. I took one of his posts and I threw it into an AI detector that teachers would use. And it said something like, this is 83% written by AI. So that really bothers me. Okay, one other piece of business before we get to the meat and potatoes with the questions from the listeners. I had a paramedic reach out from Wales to provide some clarification about something I said on the EMS Doctors podcast, where I went over that study that showed that doctors had like a 25 to 40, 39% better mortality rates when they responded with the MS as opposed to just paramedics only, which seemed insane to me. And I cited the Lyons et al. Study that showed that 37% better survival when physicians responded. And I said my speculation was that if reading the study, it seemed like it was the doctors that were giving blood and doing RSI and doing all the advanced procedures. And I said, well, if paramedics in the United States can do that, does it really make a difference that a doctor did it versus a paramedic? Is it just the procedures? And this guy reached out and said, hey, in Wales, we can do all of that. So that was not correct. I still think, though, that the biggest limitation of the study that stands is the fact that 11 out of 23 studies came from Japan, where paramedics cannot do anything for the most part. They can start an IV and give lactated ringers and throw in an SGA. Okay. So in those studies, they had physicians responding pre-hospital and patients had better outcomes. Well, duh, if the physicians can do life-saving stuff and the paramedics can't, they're going to have better life-saving outcomes. But it does, back to this Wales Lion study thing, though, it does make me wonder in the study why the physicians had such a better survival rate compared to just paramedics. Initially, it was the raw data. It was the paramedics actually had less mortality. It was 10% for paramedic only versus 12% when you had physicians thrown into the mix. But they did what they called in the study data cleaning and all the statistical analysis. And I didn't go too deep into the weeds with it because I was busy at work yesterday doing other stuff. But it translated to physicians having 37% lower chance of mortality compared to just paramedic only. That still seems nuts to me. If that's true, what's going on with the Welsh paramedics?
Right, like their training is lacking or something's going on. If it's not much better.
Now, I don't think Welsh paramedics are bad. It makes me question about the statistics.
Yeah, exactly. It's one of.
So, I have my limitations with my knowledge of statistics. I'd love for a stats nerd to look at it. But they did say the conclusion of that Lion study, it said, this study was not designed to determine which elements of the care provided by the EMRTS, that's the physician paramedic response team, were responsible for this improvement in clinical outcome. However, the proportion of patients with low GCS, high injury severity score, and who underwent tracheal intubation was significantly higher in the cohort managed by the EMRTS. It may be that the performance of time-critical interventions on scene, coupled with rapid transport to definitive care, could be explanatory factors for the improvement in mortality. So, I don't know. Lots of confounding variables and statistical questions. Anyway, let's get on to the questions from the listeners. I didn't select all of them. Some of them were super specific, and I didn't include them. Like, what do you think about the use of DDAVP compared to Arginine? Not going to cover it. And also, I don't know who asked what question. When I put the list together, I just went through the questions and typed them in, and it's been a week or two since I did that. So I have no idea who asked what. Let's get to it.
All right. So the first listener wanted to know about moving on from a job where you are amazing, but there's no opportunity for growth. You feel like the job is amazing, but there's no opportunity for growth. So what do you do there?
I don't think they felt like the job was amazing. I interpreted the question as they feel they are amazing at the job.
Oh,
I could be wrong, but that was my first thought was
okay.
like, hey, maybe you need to look in the mirror and do some self-reflection. Are you really that amazing?
Well, yeah, answer.
You might be.
Answer.
You might
answer
be.
both parts.
Okay, so I think you need to look at yourself and say, am I really that amazing? But if it is a job that you really like, but there's no opportunity for growth, I think you have to balance what you get out of the job versus what you're going to get out of a different place with more opportunity. Because in my years, I have bounced around a little bit and I have gone to places that had better opportunities for advancement, and it was a terrible mistake. Yeah, there's opportunity for promotion. There's all sorts of specialized teams, but the organization was just a shit show. So where I am now, I have always said it took me 15 years to find a place where I am truly happy and home and plan to retire from unless I get fired. But let's look at my full-time job working on the chase car in Chester County, Pennsylvania. My bosses are going to have a cow when I say this, but the pay's not the best. I could get paid way better at other places. Benefits, we have good benefits, but I've made better benefits. I've gotten better benefits at other places. And there's really no opportunity for growth. Yes, you can do things like be a field training officer. You can be on committees. You can get involved. You have input in the organization, but with a very few couple of exceptions, like very few, maybe once every 15 years, there's an opportunity for a promotion or something like that. You go work there, you are probably for the entirety of your career, and this is what I plan to do till I retire, showing up for your shift, checking the truck, and responding to calls. That's it.
I think, though, it's important to note that the reason that there's not a huge, there's not a lot of room for growth, there's not multiple positions that you can move into, is because you guys are such a small
Yes.
organization. You are very tight-knit. Everybody works very closely together, and there's not a need for like multiple levels of things.
Well, that's what I was getting to, because I'm not shitting on the organization. What I'm saying is that is something that I recognize, and I am trading that opportunity for growth and promotion in for me being really happy when I go to work, working with supportive bosses who have our back, good protocols, a good medical director, great equipment, a beautiful brand new station, and really having fun when I show up to work. I look forward to going to work most days. So that is something that I don't really care about. Hey, I'm not going to be a lieutenant, or I'm not going to be the deputy chief someday. I care about, now that I'm 42 years old and the kids are a little bit older and I've had all sorts of life experiences, I care that I show up to work and I'm happy, and that's what matters to me. If it's your goal to be a chief someday and where you are will not help you facilitate that, maybe you need to move on. But for me, it is the intangibles. Yes, do I groan when I look at my paycheck some weeks without overtime? Yes, but we pretty much do whatever we want. The standards are high, but as long as you meet the standard, they really don't mess with you. We have great equipment. You start out with 10 weeks vacation, and you take PTO whenever you want. For me, that's the important thing. It's not necessarily opportunity for growth, but if you want to be promoted and move up, find an organization that'll let you do that. But I will say, buyer beware.
I want to just add to that. Obviously, it's always great to set goals for yourself and to, strive to be the best that you can, and shoot for the stars if you want to, get promotion after promotion after promotion. But another thing is always ask yourself, like, if you're like, my goal in life is to be a chief of a department, like, really think about that. And why is that your goal? Do you really want to be a chief of a department, or does that just sound like a cool thing?
That was my goal.
A lot of
I was a
times-
megalomaniac.
A lot of times it's like you just get this bug and you're like, oh, that's what I'm going to do. Like, I'm going to be awesome. I'm going to be the chief. But if you really sit and think about it, do you really want the job that entails? Do you really want everything that goes along with it? Or does it just sound cool? And that, I think, can help save you a lot of time in life too. Maybe it's fine to try things out, but maybe, skipping over things if it's not really what you see yourself doing and you just think it's kind of,
Being the boss sucks.
yeah.
Being the boss is terrible. I haven't been the top boss, but I've been pretty damn close. It's the worst job on earth, in my opinion. All right.
All right.
Move on to a different question,
All right.
please.
So how do you recommend someone gets into EMS education?
It's pretty easy, actually. There's always opportunities to teach Con Ed. I have found that if you want to get in and teach a class or a lecture, it's very easy to do. You can build your own continuing education class. Like in Pennsylvania, I can, or any Joe Schmo paramedic can do the hard work, put together a course for however many hours they want it to be, and they can submit it to their region and get it approved for CEUs. And then you can go to your agency and say, hey, I put together this class. I already got it approved for CEUs. And of course, your bosses are going to say, yeah, free education. Hell yeah, let's do it. Also, there's always opportunities. Reach out to instructors at schools, at continuing education businesses, and say, hey, I'm interested. Can I come teach a lecture? That's all I want to do. I want to get into it. Can I teach a class? And normally these people start these continuing ed businesses with these lofty goals of providing continuing ed, and they burn out after a while because they're the only ones doing it, or one of only 3. And they will go, yes, please, thank you. Please, can you come teach 12 other classes? So I have found that in EMS, it's relatively easy to get into education. That being said, it ain't that easy being an EMS educator. It is easier said than done. I actually had a guy, he made a comment, or he DM'd me this week about how he thinks he's a very good paramedic, and he did his first foray as an EMS educator, gave his first lecture, and he bombed it. And I said, I applaud your self-awareness, but don't sell yourself short, because that's very common. It is not as easy as it looks. So what I will say now, as an experienced educator who I have bombed some lectures and I have nailed some lectures, and I know my strengths and my weaknesses when it comes to education. What I will say is prepare, study. When I am going to teach the flight medical provider class in a different area, I am sitting at that airport. Yes, I may be in an airport bar having a $24 Blue Moon, but I am studying my notes and studying the PubMed and the blogs, refreshing my mind, getting my brain ready for what I'm going to teach. It is exceedingly apparent when somebody has not prepared and they think, oh yeah, I know this, I can just wing it. And it's brutal to sit through as a student. The students get very judgmental about it, and rightfully so. You can very quickly lose credibility. And as a co-instructor, it is very cringe to watch the class know that the person who is doing the lecture has not prepared. And you could see that the class is 1, uninterested, and 2, judging the person. So prepare.
You also, aside from looking over things in the airport, you usually the night before a class, you review your notes in the hotel or the Airbnb or whatever, and you wake up in the morning and you review it again.
Yeah,
Like, it's a lot.
I will be in the hotel by myself, or if it's a local class, I'll be in the basement the night before, because this is where I have the studio and the office. In the basement, literally pacing around my computer, kind of mentally going through the lecture in my head. I don't out loud recite the lecture, but I will just pace around and go through the slides and be imagining, sometimes quietly, like mouthing what I'm going to say. It's a lot of prep. It ain't that easy.
And I always think it's kind of funny and crazy to see, because I know that you know this material. You know it inside and out. You know it in your sleep. You have taught it forever.
Not neonatology.
And if you don't know, that's what I was going to say. If you don't know something, you either you really do brush up on it, or you ask somebody else who's co-teaching, do you want to teach this lecture, whatever, somebody who has more background in it. But the fact that you know the material so well and you still take the initiative to prepare so much, I think says a lot. And somebody who is not as well prepared, and doesn't do that, it's apparent when you go to classes. So
Thanks.
okay. So severe head trauma with AMS, how to balance 30 degrees head of bed with spinal precautions.
Yes, this is a valid question. How to balance 30-degree head of bed. You elevate, for people who don't know what this person is talking about, with neuro patients, you want to elevate. I know there's been some research to the contrary, I think, over the last year, but the standard practice is you elevate the head of the bed 30 degrees to facilitate venous drainage. It helps the brain drain blood out of it back to the body, helps to reduce intracranial pressure. So you do, for right now, definitely want to raise the head of the bed 30 degrees. I believe it's the Jefferson Manual of Neurocritical Care has that listed as a tier 1 intervention. So kind of a big deal. That being said, spinal precautions, which are not evidence-based in my opinion, but how do you balance that? Well, I looked it up for this, and it confirms what I do and what I've always thought. You put the C-collar on them and just raise the head of the bed 30 degrees. Now, the resource I found, and I don't have the reference right in front of me, but it said no more than 30 degrees. But yeah, throw the C-collar on for show. I didn't say that. And then just raise the head of the bed 30 degrees. Obviously, always follow your protocols, follow medical direction, but that's what we do. That's what I do.
Okay.
Yeah.
Your thoughts on Narcan. Is it a miracle drug or a cover-up for poor ventilation?
So I tend to have controversial takes on Narcan. I am all about Team Narcan. I love Narcan, not for myself. So yes, follow your protocols. We, as EMS providers, are delivering emergency medical care to the patient. The emergency medical care standard of care for an opiate overdose is to provide ventilation and oxygenation. That is the priority. A and B come way before N for naloxone. So that is the truth. That being said, it has become cool in EMS and in vogue I've noticed in the blogs and in the comments to say, what they really need is oxygenation, ventilation. They don't lack Narcan, they lack oxygen. I get that. Yes. But you have an antidote in your bag, use it. There was a blog post a while ago, before I even started the podcast, and I pissed the person who writes the blog off because I commented that said that we should just be intubating narcotic overdoses and letting the drug wear off. You worked for almost 10 years in a busy urban ER. What would happen? What would now retired Dr. M do if the Newcastle County Medic 1 brought in an opiate overdose to your busy ER and said, hey, we thought it was good patient care to just intubate them? What would he have done?
Lose his mind, probably knock all the charts off the rack of the other patients, lose his mind. You can't do that. And especially in a setting where you have overdose after overdose after overdose, you would never have an empty room without an intubated patient. And you would be overrun with intubated overdoses. It's
Yes.
crazy. And it's just piss poor patient care.
So you're thinking logistics, which is great. But for the patient, you have a fucking antidote in your bag.
And you're
Give it.
Right. You don't need to do an extra higher risk procedure.
So yes, they need oxygenation, right. They need ventilation, but they also, if it's an opiate overdose, they also need Narcan.
Right.
That's just my opinion, 100%. No, don't slam in 2 milligrams like we used to. No, that's dumb. I'm all about giving a little dose and just having them breathe on their own again and monitoring them then. I am all about that. But it has become cool to just say, no, they don't need Narcan. They just need oxygenation and ventilation. Both things are true. they need oxygenation and ventilation, and they need Narcan. And now here's where I'm going to say something exquisitely controversial that's going to get everybody's panties in a twist.
Oh, no.
I am starting to question whether they need oxygenation and ventilation before the Narcan. I am not saying to not do it. When I work tonight, if I go to an opiate overdose, before I give somebody Narcan, you will see me there with the bag valve mask hooked up to 100% oxygen, providing oxygenation. Follow your protocols. I have questions, though, because everybody on planet Earth now has nasal Narcan.
That's what I was just going to ask you. Is it because you feel like you could administer it so quickly and then provide oxygen immediately following, or what do you?
What I'm thinking is that we get called for countless cardiac arrests that come in as 27-year-old male, 32-year-old female, CPR in progress, possible overdose. You know damn well the family does not have an oxygen tank and they're not delivering bag valve mask ventilations to the patient. They're probably not even providing mouth-to-mouth respiration. And they give nasal Narcan. The patient is awake and oriented and breathing fine when we get there. So I would like to see a study. It's never going to happen because of the Human Subjects Board and clinical equipoise, however you say it. But I would love to see a randomized control trial that's never going to happen of oxygenation and ventilation with Narcan, or just straight up 2 to 4 milligrams of Narcan up the nose with nothing. My speculation is that you would have similar outcomes, but oxygenate and ventilate your patients. But those are my questions.
Interesting.
Yeah.
All right. What type of calls, if any, take you far outside of your comfort zone? I know what you're going to say, I think.
What?
Home birth.
Childbirth. That is the answer. I have delivered babies. I have delivered placentae. I have, thank God, never have had a complicated delivery. I've responded to a delivery where the baby was stillborn and we had to resuscitate the baby, but the baby had been delivered before I got there. But yes, I actually love OB.
It's very interesting.
It's fascinating, and the patients are complex. I had a seizing eclamptic patient in the fall. I thoroughly enjoyed that call. Not for her, I felt bad for her, but I rendered her very good care. It was challenging. I'm that nerd that when we get a high-risk OB flight, I go, sweet. I love OB up until the point when the vagina gets involved. All right. Anything involving a baby maybe coming out, I can handle it. I'm confident in my ability to handle it, but I will, like, heart pounding, start sweating because I'm not familiar with it. I don't like it. And frankly, I think I have a phobia of seeing a vagina with a baby coming out of it. I don't know why.
Most people don't really like that.
I hate it. I absolutely hate it. There's also a lot of variables. Now you have 2 patients. Some places say, oh, you can't transport the baby with the mom. You need a separate ambulance for safety. Or now we're using the NHTSA guidelines where you can use this type of car seat, but they have to be in this type of seat with this type of harness. It is a pain. OBs can be very difficult to deal with. I don't like dealing with them. We had a home delivery this week, and I won't go into massive amounts of details, but it was a family who, they seemed like a lovely family. They were very nice people. The delivery went fine. The baby was beautiful, fine. The mom had to go to the hospital because after a few hours, mom was unwell. The family thankfully called 911. They didn't try to do the natural hippie thing and just keep her at home. So they called 911 and they wanted the mom transported to the hospital, but they wanted to keep the baby at home with the father. And we all were like, how the hell is the baby going to eat? This is a terrible idea. So we were there for about an hour having this conversation. We had a medical, because they had no prenatal care. So we had a medical control physician on the phone explaining everything that we explained. It was a whole thing, but these people weren't drunk. They weren't homicidal. They weren't intoxicated on other substances. You can only do what you can't, we're not the Gestapo. We can't force somebody into a vehicle and take them. So the mom and the father refused transport for the baby against everybody's adamant recommendation that they go to the hospital. So my partner Cam takes the mom to the hospital, and I told Cam, because she's young and newer in the profession, people know her from the podcast, I said, just heads up, OB, when you show up with this patient who has no connection to their practice, she has a placenta that is half hanging out of her and stuck and now bleeding, and you show up with no baby, they're going to lose their goddamn minds. So normally I would talk crap on doctors like that, but I do sympathize with the OB, but just heads up, he or she is going to lose their fucking mind when you show up. And of course they did. And I told her, I said, when you showed up, you should have just went, fuck, like, shit. Oh, shit. I knew there was something we were forgetting.
You would have done that.
I probably would have.
Then you would have gotten
Yeah.
from your mouth, I'm sure.
But yeah, anything involving a baby and a vagina, I don't like. That's it. It's not me being funny. That is, you want to see me truly uncomfortable, it's those calls.
All right. Any other types of calls, or mostly just that? I think.
I used to be scared of pediatrics. I talked about this in the Sick Little Kids episode, and I have come to the realization now that over the last 2 years, I've had more crashing, dying peds patients than I had in my entire career. I don't know why it was. And it wasn't like it was COVID or RS. It was a combination. It was
Trauma.
It was trauma. It was that stillborn kid. It was everything. It was a couple kids were suffocated, like moms rolling over on top of babies during the night and falling asleep. I mean, it was tragic. Yeah, I had some septic shock. I had some really, really sick kids that I had to manage, and I'm by myself in a single medic chase car. So I felt bad for the kids, but I got a lot of peds experience in those 2 years, and I have come to realize that they're easy to take care of. It's basic. A couple of them, it was just straight up BLS care that I provided the kids, and a couple of them had saved their lives.
Yeah.
So I used to be scared of peds, no longer.
Cool. All right. Is there such thing as too sick to transport in HEMS?
Did a podcast on this a while ago. Steve Titleman came on, one of my coworkers, and we talked about this. I think that it's a cop-out to say that this patient is too sick to transport. When I started doing critical care transport, and on my old team, there were some old, I don't know if I'd use the word crusty, but there were some old transport and flight providers that would say, oh, this patient's too sick, we can't put them in a helicopter. And it's like, well, he's having a massive aortic dissection. Like, he's going to die here unless he goes to the operating table. I know he's got a pressure of shit over shit, but if he codes in the helicopter, he codes in the helicopter. Is he going to die here? Are we going to give him a fighting chance? So I do think that there is not such a thing as too sick to transport in HEMS or in general.
Unless, like, would you say the only time that would be the case is if the patient, you're at the bedside at the sending hospital and they're actively coding, you wouldn't then take them.
Well, that's what I was going to say.
Sorry.
There is such a thing as stupid to transport right now. So there are some teams that have a super emphasis on time. We got to reduce the bedside time, and the patient crashes and burns in the helicopter. And it's, had you slowed down and taken 10, 15, 20, sometimes even more to stabilize that patient before you put them in a helicopter, maybe they wouldn't have crashed during the transport. I am all about fending off the bad juju with blood pressors, talking to the doctor on a really unstable patient before we transport them. I am all about that. I am also about not transporting people just for the sake of transporting them. Now, what do I mean by that? We went down during COVID to transport this sick COVID patient. He was on BiPAP. He had to go to my hospital for they told us ICU care not available at the sending facility, the general catch-all justification for transport. So we didn't have Hamilton vents at the time. We switched them over to the Revel vent, and shocking, it shut down because the Revel vent does shit jobs keeping up with BiPAP patients who are really air hungry. So I went to the intensivist who was in that community hospital. I actually went to high school with him. I went up to him. I was like, yo, Mike, like, this guy's not tolerating our BiPAP. We tried him on a non-rebreather and he plummeted to like 50% like a stone. We have him back on the bedside BiPAP. I don't know what to do. Like, we've done all this stuff. And he came in the room. He looked at him. He goes, you know what? This guy is only going to your hospital for, I forget what it was. I think it was like a VQ scan or something.
Wow.
And he said, hey, the benefit of what we're going to get from that test doesn't justify the risk. He was like, you know, he can stay here. He doesn't need the VQ scan. You know, it would be nice, but I'd rather him be here and tolerate the BiPAP than go. So yes, also another time there was a patient with ruptured esophageal varices that we went to transport. Hot mess. We showed up and they now have a level 1 infuser up. There's blood everywhere. They're putting in a Blakemore tube. The guy is crashing and burning actively. The sending doc said he coded twice already. We're now giving him his like 700th unit of blood. And his heart rate was in the 30s and going down, and he started to code again. And I looked at the doc. I was like, hey, we're not transporting this, right? And he's like, no, he's dead. So yes, sometimes I say not too sick to transport, but fruitless or stupid to transport does exist.
That makes sense. Good.
We do a lot of transporting patients in HEMS, especially just so they can die in another location.
Yeah, that is crazy.
Like when we get called to fly a 99-year-old with a massive head bleed, it makes no sense to me that we do that. And we do follow-ups on all of our flights. So I'll go into the patient's chart and it'll say, patient arrived intubated on XYZ drug on, no GCS of 3, no pupillary reflexes, brain death protocol initiated, family was contacted, patient extubated and died like 2 hours after we flew them. That happens all the time. Anyway.
That's kind of ridiculous. So not too sick to transport, but does it make sense? And is it going to benefit the patient?
Yes.
Let's see. How do you build confidence as a medic student? I feel like you've talked about this multiple times.
Constantly. But if I had to boil it down to one thing, know the material. Master the coursework. That requires hard work. That requires reading the textbook, not just going to lectures. You have to know that textbook backwards and forwards. That is how you will build confidence as a medic student.
And put in the work yourself. Like you said, you can't be expected to be spoon-fed absolutely everything. Like if you're not getting the instruction that you need, you have to take the initiative as well, right?
Yeah. The spoon feeding drives me nuts. I tell people all the time, look it up and come back to me if you can't find it. I don't know why I do this. I opened up TikTok for the first time in a week and I was going through some of the comments and there was a comment on my aortic dissection reel. I wrote, what is a false lumen? Fucking look it up, you lazy asshole.
You could be a little bit nicer.
I didn't write that, but
Yeah,
I thought that.
I know.
Okay.
All right. And sorry if that was your question, whoever is out there listening. Okay. Looking back, would you recommend a career in EMS to your children?
Yes. At the right place. I would recommend a career in EMS. Life is a collection of experiences. This is a ticket to the, what did they say from that show, Southland? A front row seat ticket to the greatest show on earth. 100%. I am not of the I come from the generation where it's you had to go to college. You were a failure if you didn't go to college. I personally think that my degree was a waste of time. I would totally recommend to them a career in EMS at the right place, in the right system. So if Elena came, because she wants to be a paramedic, if she said, I want to work for FDNY EMS, I'd say, fuck
Nope.
no, absolutely not. But if she came to me and said, hey, I want to go work for Newcastle County or Sussex County, not Kent County.
Southern Sussex.
Yeah, I would say, hey, I support you in that. If my kids wanted to go to trade school and become a plumber or an electrician, totally support that. But if they came to me and said, hey, it's $70,000 a year to go here for a communications degree, I support you on that. Totally do. I don't know if we're going to pay for it, but if you want to do that, you find a way to do it.
We will, but it's just not, I mean.
But yes, I would recommend to them, and I have recommended to them, a career in EMS.
I was glad you brought up Elena, because I was just gonna say, do any of your children want to go into EMS?
We have friends that aren't in public safety or healthcare, and healthcare, like acute care healthcare. And we go out to dinner with them. They are boring as shit. Like, yeah, okay, this guy makes quintuple what I make working for PayPal, and they, they'd probably have their eyes pop out of their head if they saw my paycheck. But they're just boring, fucking boring people. They have nothing to contribute. My friend Brad, from college, man, I felt bad for him because he went into business, and the group of friends were like, he went into business. Dan became
PMT.
probation officer. John became a state trooper, and I became a paramedic. And we would all hang out at the bar before we had kids and when we could do this stuff, and we would go to the bar every week. And we'd all, Dan, John, and I, and you as an ER nurse, would be telling stories. And poor Brad had nothing to contribute. And he was like a cat watching a ping pong game, watching all of us go back and forth and talk about our stories. And I think those stories, not only are they cool, but they build up life experience, street smarts, and make you successful.
I do always feel bad when you're in that situation. That still happens now sometimes. I mean, we were out a couple weeks ago, and there was only one person who was not in the medical field. And I feel like the conversation always gets monopolized by the medical people, and then that one person is out. So, I mean,
well, what the fuck else are they going to, like, what are they going to say? Like, oh, let me tell you about this equity firm that
I just feel bad. I mean, it's like we all have our own world, but those other people all have their own world, and they're probably like, okay, like what,
Yeah.
I don't know. It's just a weird dynamic, but we are almost always hanging out with people that can relate to us. The podcast can relate to us, all of that. But, we have to also recognize that there are other people out there, and they might think their lives are awesome and cool too.
Yeah, it's like, oh, I work at a venture capital equity firm, or I am a dentist, or I am a wealth manager. What did you do at work yesterday? Well, I pronounced a guy dead who died choking himself while jerking off in his garage. I don't know. I'm very happy with my station in life.
I'm glad.
All right.
Next. Any words of advice for a new medic who's struggling on some calls?
This is another, I answer this constantly. Ask yourself the hard questions. Why are you struggling? And I have said this a lot recently. A lot of people act introspective, and they think they're being introspective, and they think they want the constructive criticism. But when they get answers for why they may not be doing well, or why they are struggling, they don't like what they hear, and they get pissed off, and they repel it. So be open to criticism. Brace yourself. If you're struggling, it means you're probably fucking something up. Or it could just be that you have yourself on a pedestal. I've seen people who say, hey, I feel like I'm just not getting it. And I'm like, you've been 6 months out of paramedic school. The first 2 years suck. It's doubt. It's fucking up. It's imposter syndrome.
I was just going to say, could be that too.
So give yourself some grace. Ask yourself what's good, what could be better. I had this one guy, he's like, I just feel like I'm just not ready. Like, that's exactly how you should feel as a paramedic student getting ready to graduate, because you're not ready. And he was like, my patients deserve better. It's like, shut the fuck up, dude. Like, quit the drama. Everybody has to start somewhere. And healthcare, you're going to get some experienced providers, and sometimes you're going to get the doctor who you don't know is going, oh shit, this is the first patient whose head I've had to drill in before.
Mhm.
That's just the way the
There's
cookie crumbles.
always going to be the first
You-
time you have to do stuff.
You got to start somewhere. So give yourself some grace, but also be accepting of the fact that it is a kick in the balls to the ego to ask somebody, hey, what am I screwing up? And for them to bluntly tell you, here's what you're screwing up. It sucks. But also, if you're really struggling, I would say slow down and recalibrate. If you feel like you're in over your head, just stop, take a breath, do a 360, look around the room, look at your patient from head to toe, and start over. ABC. That's what I would say.
That is good advice. What is your biggest passion when it comes to pre-hospital medicine?
Biggest passion. So I do the education, I do the content creation, but my biggest passion is doing the fucking job. Getting out there, responding to calls. I like the education, I like the content creation. I have different areas that I like, TEMS. But at the end of the day, getting a dispatch and responding to a call is my passion.
Mhm.
Being, what do they call it? Being now the new term is being a street goon.
I haven't heard that one yet.
I
but-
think it's more of a cop thing. The Copville guy, I think, coined it.
Okay.
Um,
I think that's true. I mean, you've done everything basically in this field, all kinds of different positions, and you always seem to enjoy going back to being a street medic the most, more than management, more than flight, more than anything really.
One of my flaws, and I'm aware of this, is that I tend to look down on people who have a different passion than me in this profession. So I do, with the memes and the content. I shit a lot on people who aren't responding to calls every day, like the admins, the educators. I will poke fun at them. I will always poke fun at somebody who has a job title of telemetry lieutenant, or what they call these condition bosses in New York City, apparently, who just show up on calls and start barking orders and
Monitor
don't do
the
anything.
conditions of the suit. That's what they do.
Sounds retarded. But we need good admins. We need good educators. And if that is their passion, we need people like that in those positions if they're the right person and their intentions are good. So I think that's a long-winded way of me saying that I do honor that people have other passions than me, but my passion is getting in the car and getting called to a hot job.
I agree. What are your thoughts on peer review in clinical QA?
Mixed thoughts. I see why places want to do mandatory peer QA. I also have worked in places where peer QA is voluntary. So I've seen it work well. I've also seen it not work well. I have seen one or two people who want to do peer QA get involved, and they become these little clinical Napoleons that they will write flags that are things like, hey, I noticed this patient's blood pressure was 87/53 and then it wasn't until 5 minutes later that you started a Levophed drip. From my experience, it takes 47.25 seconds to mix and hang a Levophed drip. So why was there such a delay in getting the infusion up? And it's like, shut the fuck up, dude. There are people like that. As far as mandatory QA, I think this is what the question was getting at. I think it can be problematic. We do mandatory QA now, mandatory peer QA at my ground job. But it's strictly, if you want to look at the clinical stuff, you can, but the QA is the incident number right? Do you have the township code correct? It's just basic stuff like that. I have no problem with that because it helps the bosses out with the stat tracking. That's fine. Did you attach a 12 lead to it? It's stuff like that. But I have done mandatory peer QA. The flight team where I started, we did mandatory QA. You would QA the off-going cruise charts. I did what was called the second level QA, which was where I was more of a clinical QAer. So I would review the chart, review what the peer reviewer wrote, and then I would do the, like, I guess what? Like the alternate Q&A.
Q&A, sorry.
There was this EMT used to call it Q&A. Hey, Mike, I did my Q&A today. So I found there are 3 types of people who do mandatory QA. You're going to have one, they're going to do the job. They're going to log in, they're going to make sure everything's correct. And if there's a glaring clinical question, they're going to ask it and then they're going to send it on its way. And usually it's a good job. Then I have found that there is that asshole who weaponizes the QA or who QAs it according to how they think the chart should have been or the patient care should have been performed. And those are problematic. But what would really make me go nuts doing the second level QA is when I would open up the QA system, TAMA. Air Methods people will know what I'm talking about. And I would see the QA note before I would open up the chart, and it would say, good chart. And then I would open up the chart.
There'd be 50 million comments.
No, there would be nothing in the chart. It would just be a set of vital signs and no, like the HPI would be car accident. And there would be like, motherfucker, did you even peer review the chart? Good chart? Are you kidding me? That would drive me nuts. So I think mandatory peer QA can be problematic. I don't think there's a good answer.
And I think that's probably like the case in any type of field that gets stuff QA'd, not just this. I mean, I think there's always going to be good reviewers and people that do a shitty job with it. All right. So how to handle it when older medics don't agree with aggressive, in quote, treatments.
I talked about this on the Boomer Medics episode. If they are really being a bump on a log and not performing well and they just want to be lazy, outperform them. And if it's really bothering you that much, just say, you know what? Why don't you drive? I'll take this patient. So that's what I would do. That being said, get off your fucking high horse and consider that maybe, just maybe, that old medic might be onto something and they might be right. Sometimes less is more. Actually, I find most of the time less is more. I've become very much a less is more paramedic. They might be right. I have seen a lot of people who say, I'm an aggressive provider, and the treatments that they render can be very unnecessary, dangerous, and they can end up looking stupid. Case in point. We did a flight it's been a few years at this point, came in as a stabbing. And we land at this baseball field and it's next to this low rent apartment complex. There's a chain link fence separating the sports field from the low rent apartment complex. And we can see the police units and the ambulance and they're sitting there, they're sitting there, they're sitting there, they're sitting there, they're sitting there. And I said, I guarantee you they are dicking around doing an RSI with that patient in the back of the ambulance right now. Sure enough, they deliver us this patient. She's intubated when we get in the back of the ambulance. They were probably there for 20 minutes. They deliver us this patient. She's intubated. She's got rock stable vital signs. She was fat. She was a big girl and she had her arm completely filleted open. It was an ugly looking wound and it was filleted open. All the subcutaneous fat was hanging out. It looked like something from a gore website, but it wasn't a life-threatening injury. It was ugly, but honestly, it was probably freaking BLS. And I said, why is she intubated? And they said altered mental status. And they're giving the report. I said, you just told me she had GCS of 15 when you guys arrived. Basically, they got caught up in the moment and they intubated this patient because she was drunk and she had this glaringly ugly wound. So we arrived at the trauma center and they asked, why is the patient intubated? I said, I don't know. They said older mental status, but they told us GCS of 15. So after the third person in the trauma bay came in, because this was an unorganized trauma response, it wasn't at our hospital. After the third person asked, well, why'd you guys tube this patient? I was like, yo, everybody listen. We were delivered this lady with an endotracheal tube sticking out of her mouth. With the story we were told, we wouldn't have tubed her either, but we sure as hell weren't going to extubate her.
Yeah.
So wasn't us that tubed her. But this crew looks stupid because they wanted to be aggressive. So yes, less is more sometimes. I had a guy, it was a nursing home call, 3:00 in the morning, this norovirus bug going around. I walked in and this man, I think I put in my HPI. I didn't get a flag on it, but I think I put in my scene description the patient looked like he had died last week. He's an 80-some-year-old. Of course, he's a full code. He was white as a sheet. He had a pressure of 52 systolic, no pulses or no palpable radial pulses, a weak carotid. He's stone unconscious, and he had no cap refill. I thought, great, he's going to code during the transport. So all the hardcore stuff is going through my head. I'm like, got to get a Levophed infusion going on this guy, got to get fluids up, got to push dose epi, got to get ready to intubate him because he's got no mental status. And then I thought, you know what? This guy has norovirus. He's probably shit out all of his volume. Let me give him a liter of lactated ringers and see what happens before I start doing all of this stuff. This motherfucker had a GCS of 15 and pulses and a good blood pressure when we got to the hospital 35 minutes later. And I think of all this unnecessary stuff I could have done. And I would have done that 15 years ago. I would have killed him by intubating him.
Mm-hmm.
Been like, what? Good patient care. So sometimes less is more. That old medic might be right. I'm not saying they are right.
Yeah, not in every situation, but certain things they may be correct on. I think that's all you had for your listener comments this time around. I think you said you may have some others, but
Yeah.
do a separate.
Yeah. Wes and Gwenny, I'm recording with them on Thursday. I've got a whole bunch of other questions. So that's what I got. Thanks for coming on the podcast.
Sure.
It's been a hot minute. This was totally unscripted.
Yeah.
All right. So thanks, people, for tuning in. Thank you, Ashley, for coming back. Subscribe to the Patreon if you don't subscribe already. We really appreciate it. You guys always get on me for that. And yeah.
Elena might come on to one of the next podcasts. She really wants to come on, our oldest daughter. She's like, I want to be on the podcast. So we don't know what she's going to say.
Now she got dumped by her boyfriend. She's got a lot of extra time on her hands. There's been a lot of drama in the house. All right. Thank you. Goodbye.